Welcome everyone to a wonderful evening of knowledge and enlightenment. Today we are going to discuss on recurrent pregnancy loss, evidence-based management with the experts under the aegis of FOXY, Food and Drug and Medico-Surgical Equipment Committee. This webinar is brought to you by Bridging Bharat Initiatives by Bharat Serums and Vaccines. To start the program, I would like to introduce our moderator for today's evening, that is Dr. Vidya Thobi. Madam is the professor and head department of Obs and Gynae, Al-Amin Medical College, Vijaypur, chairperson, Foxy Food and Drug Medico-Surgical Equipment Committee, national corresponding editor for journal Jogi, organizing chairperson KSOGA, treasurer KSOGA, EC member KSC AGOI, academic council member Women's University Vijaypur, Al-Amin Journal of Medical Sciences editorial board, an undergraduate and postgraduate examiner, paper setter, and postgraduate guide teaching for last 30 years. Welcome, madam.
Thank you. Thank you very much for this wonderful words. I bring greetings from Food, Drugs and Medical Surgical Equipment Committee, FOXY. And I thank Dr. Alpesh Gandhi, our FOXY President, Dr. Ramani Devi, our Vice President, and Dr. Jaideep Tank, our Secretary General, for giving this opportunity for conducting this wonderful webinar. We have heard about recurrent pregnancy loss in many of the webinars, but this is one of the best, I think, faculties I could get for this webinar. And I hope that all the viewers definitely will enjoy this. Now I welcome Dr. Alpesh Gandhi, sir, our FOXY president, and he has got many credentials, and his theme for this year was safety first, and so many webinars and so many things, it's safety behind we have conducted under his leadership. I must congratulate him for various initiatives, including CSIR initiatives, and he is very much supportive for my committee. We have conducted many activities under his leadership. He is also has got many books at his credits, and I was also a contributor for his Principles of Critical Care in Obstetrics, and it was a wonderful book, I must say. And when he was vice president, he has conducted many critical care workshops as well. And I welcome sir to address his presidential address for this gathering. Few words, sir, from you.
Thank you, Dr. Vidya. Thank you for the kind introduction, kind word. Dear Jaideep, Dr. Mala, Dr. Amit, Dr. Tushar Bhai, Dr. Sanjay Makwana, and Dr. Manju Puri Madam, Dr. Ramani Devi. A very good afternoon to all of you. I extend a warm welcome on behalf of FOXY. At the beginning, I would like to congratulate Dr. Vidya Thobi, FOXY Committee Chairperson, for the excellent work. I can see all my 27 committee chairpersons are working very actively throughout during this difficult time of COVID-19. Dr. Vidya is very, not only active, but very, very enthusiastic. Every day I am receiving phone calls from Dr. Vidya for different projects.
Yes.
And I think Ramani Devi must also be getting phone calls from Dr. Vidya.
Not one, twice.
For today's topic, it is we all know that's a very, very important topic. The frustrations and the helplessness that an obstetrician feels when he or she has to counsel a patient about yet another failed pregnancy is something we are all acutely aware of. Unfortunately, recurrent pregnancy loss can stress just as heavily on the physician as it does on a patient. How does one tackle this situation? How can we provide the patients with enough hope that they do not sink into depression or start hopping from one doctor to another? And then, more importantly, how can we prevent the next pregnancy loss?
Okay.
In the recent years,
Yeah, fine.
numerous studies have given us insights into the management of RPL, and although there is still no definite cause that can be pinpointed, even though we have a number of methods by which we can manage these patients and deliver a successful pregnancy outcome. I hope all the delegates will be benefited from the scientific deliberations which is going to be done in this webinar by the experts of on RPL across India. I welcome chairpersons Dr. Tushar Shah and Dr. Sanjay Makwana,
Yes.
are very experienced, and personally I will also like to say a very good friend of mine,
Yes.
and both of are not only friends but many times I am also taking guidance sometimes from them. Amit, a very close friend. Mala, Mala is one of the advisor for this year. Dr. Manju Madam is doing excellent work in this difficult time of COVID-19, managing so many COVID patients in her hospital. Even though she has agreed to join and spare some time for us. So thank you, Dr. Manju Puri. Thank you, Dr. Tushar Bhai. Thank you, Dr. Sanjay Bhai. Thank you very much to all of you. And I wish a grand success to this webinar. I wish all of you safety. And once again, I congratulate Dr. Vidya. Thank you very much.
Thank you, sir, for those kind words and for joining this webinar and all the support you have extended to my committee. And as always, thank you very much, sir. And I hope, if not busy, you can join my webinar also and enjoy the academic feast. Yes. I then welcome Dr. Ramani Devi, our Vice President. She is very supportive, as Dr. Alpesh was telling, and I always trouble her for my various committee programs. She is a vice president 2020, and she has got many credentials for her. She is a gold medalist. Then she has won many prizes. She was a successful chairperson of endometriosis committee FOXY, and that was the best. She has won best committee award for that year for that committee. She is a Woman of the Year award also. She has got in 2013 Woman Achiever Award by Citizens of Trichy 2015, and there are innumerable credentials for her to her credit. So I wish Dr. Ramani to say few words about the committee as well as today's topic. Welcome, Dr. Ramani.
Good evening, everybody. Respected President Dr. Alpesh, senior members of the profession, moderators, Dr. Jaideep Tank, Secretary of FOXY, and Dr. Sanjay Makwana, and Dr. Manju Puri, and my dear friend Dr. Vidya Dupi, who is currently the chairperson of this Food and Drug and Medical Surgical Committee of FOXY. She is really doing a wonderful work, like Dr. Alpesh has been telling. I think she should continue to do such a good work in this COVID period. So now the topic today that has been taken is a very important topic, that is recurrent pregnancy loss, which we day in and out we see. And we have today with us a galaxy of stalwarts in this particular field, Dr. Mala Arora, who herself has written number of books on this particular topic of recurrent abortion, and Dr. Amit Patki, who has been involved in a lot of international trials regarding this progesterone in the role of recurrent pregnancy loss, and so many other stalwarts who are going to impart knowledge on this particular topic. Because, as Dr. Alpesh has said, it is a very difficult situation both for the consultant as well as the patient. The patient's family, they suffer from one through the mental suffering, and then the psychological problems that are associated with the couple, and the economy that is involved. So all these things matters a lot, and it is always safe to evaluate the couple in between pregnancies so that we can come to a conclusion. At least we can tell the patient the next pregnancy what she's going to have is going to be a complete one. So still, though there are so many causes for recurrent pregnancy loss, unexplained causes still matters a lot, and we do not know. We try with all sorts of medications, all sorts of stitches, whatever is possible, but at least not everybody is blessed with a child. Only we can, up to 80% of the patients, we can have a successful newborn. So this program is going to be an excellent one with the stalwarts who are going to be the participants, and I wish Dr. Vidya Dopi a grand success for this important webinar on a very, very important topic. Thank you for the opportunity.
Thank you, Dr. Ramani. I welcome now Dr. Jaideep Tank, our Secretary General Foxy. We all know him, and I need not introduce to the August gathering, but few words about him. He has contributed a lot to Foxy, and he has chaired international committees as well as he is a Deputy Secretary of AOFOG, and many publications and many credentials. And he was when I took over as a Food and Drug Committee, there was an oxytocin issue. There are many issues in Foxy. He handled it very nicely, and he was. We saw the elections recently. The elections were conducted very successfully, around 95% of voting, and everything was very fine and very fair. So I just want Dr. Jaideep Tank to tell few words, and I wish him all the best. Yeah.
Thank you very much, Dr. Vidya, for this very kind introduction, and of course the very, very kind words. I am very grateful for them, and I must congratulate you and also appreciate your enthusiasm with this wonderful series of webinars that you're doing. You have made your committee one of the most active committees in Foxy, so congratulations for that. I would also like to appreciate our very dynamic president, Dr. Alpesh Gandhi. I'm sure he's tired of me saying this, but I must say again that I can just imagine that even in this COVID times, he's making us work so hard. If there was no COVID, then I'm sure to imagine how much we would have had to work under his leadership. And of course, Dr. Ramani Devi, who's always very kind and gracious and very helpful. The chairpersons, Dr. Sanjay Makwana, Dr. Tushar, and of course, you have a wonderful faculty with some of the leading lights in the field, Dr. Mala Arora, Amit, and Dr. Manju Puri. I confess that as far as recurrent pregnancy loss is concerned, whenever I see a patient who has a RPL, I always hope that she has a uterine anomaly. At least then I get to tell her that, I think that it's because of this. Because everything else in recurrent pregnancy loss is simply so abstract sometimes, and, the norms are not really so clear. And here you have decided to handle some of the most difficult aspects of recurrent pregnancy loss with genetic causes and alloimmune causes and prothrombotic states in RPL evidence-based management. So congratulations both on your selection of the topic as well as selection of the faculty. Thank you very much for having me. It's been a real pleasure and privilege. Thank you again.
Thank you.
Jaideep, can you please inform about N95 mask and face shield, which we have sent recently to the colleges?
Thank you, Alpesh bhai. So recently we had announced it through Dr. Alpesh that Foxy would be sending N95 masks. We have sent 100 of them and 40 face shields for every medical college. And I'm happy to tell you that around over 150 medical colleges have received
Yeah.
this as a very small token of our contribution and appreciation for all the hard work they are doing. I think the email which Dr. Alpesh drafted said it all, that we know that this is in no way adequate for them, but we hope that they recognize that this is a gesture on behalf of Foxy to both appreciate and applaud all that they are doing.
Yes.
So over 150 colleges have received it, and another 20 to 25 colleges, so totally around 183 colleges will receive these N95 masks and face shields. Thank you, Alpesh Bhai, for pointing that out.
I would like to add one thing. Because of Jaideep's efforts, we could get it N95 and face shield at a quite reasonable rate. And if any society is interested, they can contact him, and he
Yes.
is based to do something for the society.
Definitely, definitely, sir. We will all
So your
say
face
that.
shield is manufactured right next door to us by Stud Helmets, who are very close friends of ours. So I can give it to you straight from the factory, wherever you want it to be dispatched at the factory.
Sure, Mala, we'll definitely keep that in mind. Thank you.
That was a very kind gesture from Foxy, and definitely it will be helping, especially in some of the government colleges in Karnataka. They are very short. There is a shortage of N95 masks and even the face shields, and our registrars and residents are struggling. So from my committee also, I had appealed the various pharmas also. And from my personal funds also, I have helped some of the people whom they were requiring these face shields and masks. So thank you, Foxy, for supporting these things. And about the COVID registry also, I must tell that we are telling everybody to fill up and send to Foxy this one website and mail. So thank you very much, all the dignitaries who have really enlightened us on this very important webinar platform. Now I welcome our chairpersons, Dr. Tushar Shah, who is an ex-professor of OBGYN of NHL Medical College and President Gujarat chapter of ISAR. He has a he is a President Gujarat chapter of ISAR and special interest in advanced infertility. And also he is a very famous endoscopic surgeon, and his areas of interest are also in high-risk pregnancies. And another chairperson, Dr. Sanjay Makwana, who is a director, Vasundhara Hospital Limited. He is working in ART since 95. He is trained in IVF from Belgium, trained more than 250 gynae in ART and endoscopy, and he has got a key interest in areas of endoscopic surgery and ART. I welcome all the three speakers who are the encyclopedias and stalwarts in their own fields. Dr. Mala Arora, Dr. Amit Patki, and Dr. Manju Puri, who will be focusing all our today's topic on recurrent pregnancy loss. And there are few questions already we have received, and at the end of all the three topics, we will be discussing a few of these questions. So over to my chairpersons to invite our speakers, and let us have fruitful academic discussions. Thank you very much. Dr. Tushar Shah, please. Sir.
I think Sanjay will go into okay.
Okay, Dr. Sanjay can introduce our Dr. Mala.
Okay. First of all, thanks to Foxy President Dr. Alpesh Bhai and the Secretary General Dr. Jaideep Tar for keeping the momentum very high in the tough time of COVID. And the academics are really going like anything, and everybody is very much involved. So thanks goes to the team of Foxy. My thanks goes to Dr. Vidya, the chairperson of the committee, as well as Dr. Ramani Devi for organizing this webinar. I'll be introducing the first speaker of this webinar, which is focused on the RPL, and I'll be introducing Dr. Mala Arora. Dr. Mala Arora is a very close friend of mine for quite a long period, and she's very well known in the field of RPL. She was also the chairperson of ICOG in 2017. She was vice president Foxy in 2011. She is the chief editor of the Recurrent Pregnancy Laws in 2003, 7 and 18. She was also the chief editor of World Clinics in Obstetrics and Gynecology in volume 1 to 10, editor-in-chief of Yearbook of OBGY in 18, 19 and 20. She has also edited the first trimester of pregnancy, especially the hyperhomocystinemia, associate editor of International Journal of Infertility and the Fetal Medicines. She was the reviewer of the British Journal of OBGY. And she has a lot of other accounts in our site. With this, I welcome Dr. Mala Arora for this webinar.
Thank you, Sanjay. Can I start sharing my screen? Thank you, Vidya, for involving us in this webinar. And I'm so happy that I've got my very close friends as speakers on this. And I think this webinar is going to take you through the recent developments in the field of RPL. I bring you greetings from the Indian College of Obs and Gynae and Noble Hospital, Faridabad. I'm going to discuss some newer concepts in genetics and autoimmunity. And before I start, I want to just share a quote from my guru with you, which says, "Those who are inwardly content are living rightly. Happiness comes only by doing right." And I must congratulate Dr. Alpesh Bhai in this year to do. He has been doing everything that is required of a leader of Foxy, and I'm very proud to be associated with him as a scientific advisor. Now, my interest in RPL spans the last 20 years. And when I was preparing to write my first book, which came out in 2003, there was very little known about the causes of RPL. But as we progressed to 2007, then 2011 and 18, the books got fatter and fatter, and we could actually incorporate a lot of new research, which brought us to know what are the multifactorial causes of RPL. The main development in this field was the change of definition that was done by ASRM in 2012, and it said 2 or more consecutive pregnancy losses will now be classified as RPL. And that expanded the number of women that we put in that category to around 5% from 0.5 to 2%. A point of note here, and this is research by none other than Dr. Amit Patki, who is going to be a speaker, that India reports a higher incidence of miscarriage than the rest of the world. And this could be related to many factors. One of them could be subclinical endometritis that can happen due to various intrauterine procedures. It could be due to a large number of pesticides that we consume from our milk and environment. It could be due to the high stress level because of the focus on reproduction that is laid by the family and the society. So we are facing the burden of miscarriages, which is 32% versus 10%, which is the global average. And when it comes to recurrent miscarriages, our incidence is 7.4 as compared to 5%. And this was covered in the news as well. One other thing that has come to light, that when we started writing the books, we had a large group that was unclassified or unexplained. And after today's talk, I feel quite hopeful that this group would be cut down into half, because we will endeavor to explain a lot of new causes of RPL. And when we look at the causes, the 3 main causes that are making a lot of impact to explain the unexplained are the genetic factor, the autoimmunity, and the subclinical infections. So I'm going to focus on these 2 mainly, but also touch upon the infections. So I hope that by the end of my talk, this unexplained group is cut into half for all of you. Of course, the lifestyle factors we cannot change, but we need to create awareness that age is our biggest lifestyle factor that increases pregnancy loss. And you can see a woman of 45 will have almost 90% incidence of miscarriage with her own gametes. However, Our biological clock, unfortunately, does not wait for anybody, and we must inform women that the best time for them to have a baby is between 20 and 35 years. Obesity, again, both maternal and paternal obesity is associated with obstetric complications, and we must stress on fitness for fertility in the reproductive age group. And we must not forget the male factor when we talk about smoking, alcohol, tobacco, and drugs, because these factors will increase the sperm DNA fragmentation. And so far, we have only focused on the woman, but we have to check both the partners for exposure to pesticides, dry cleaning chemicals, anesthetic gases, and of course, high consumption of antigenic food. We know that human reproduction is a naturally wasteful process, and only 25% of the eggs that are ovulated will actually reach anywhere close to a live birth. And we have to rule out in a woman that has recurrent miscarriage, there will be added factors like increased genetic abnormalities, increased autoimmune conditions, anatomic conditions that will cause more pregnancy losses. It has been shown by normal studies on miscarriage products that spontaneous fetal aneuploidy is the most common cause for a spontaneous loss, particularly in the first trimester of pregnancy. And when they did genetic testing of products of conception, nearly 60% of early pregnancy losses have a chromosomal abnormality. And this risk increases with age from 9% in women who are less than 35 to around 50% in women who are more than 40. However, in RPL, the risk of having aneuploidy is lower than compared to women that have a sporadic loss. However, there is still a risk of aneuploidy. So the genetic causes I'm going to cover under three headings: spontaneous fetal aneuploidy and how do we test for it, balanced and Robertsonian translocation of the parents and what do we do about it, and sperm DNA fragmentation and should we be testing for it. So spontaneous fetal aneuploidy is very common in early pregnancy losses. So if you want to take a rough take-home message, 90% of miscarriages between 0 and 6 weeks of gestation will have an abnormal karyotype. 50% if they are between 8 and 11 weeks, because here a commoner cause is APL syndrome rather than genetics. 30% in women who miscarry at 16 to 19 weeks, and 6 to 12% if women go on to having a more than 20-week gestational age pregnancy. So when we are dealing with very early pregnancy losses, biochemical pregnancies, this is something we need to keep in mind. As we said already, there is a strong correlation between advanced maternal age and autosomal trisomy. But there is no significant association between advanced maternal age and sex chromosome monosomy or polyploidy. The largest effect of advanced maternal age is seen in trisomies of chromosomes 8, 9, 10, 13, 15, 18, 20, 21, 22. However, it is the father that contributes to sex chromosome trisomies. So if I was taking a live class, I would stop here and ask, would you do karyotyping of products of conception? And all those who say yes can probably raise a hand on the chat box. But I won't wait for a response. I would ask you, when you have done products of conception karyotyping, do you see any genetic defects, or have you come across many patients with genetic defects? The answer may be yes or no, depending on your experience, but I have to bring to light that for a long span of time, we were recommending karyotyping of products of conception. However, karyotyping is not the ideal method of genetic testing, because in 20 to 30%, there was failure of these chorionic villi to grow, and so the patient lost all her money. There was a very high maternal tissue contamination, and this paper in 2001 highlighted that nearly 70% of reports of karyotyping reported an XX chromosome. And that was not possible because we know that at least the male-female ratio should be 50-50. So there was a high maternal cell contamination, which is why we were getting so many XX reports. And many embryos that actually looked abnormal on embryoscopy or even when they were aborting, they had a normal karyotype. So it was frustrating when we relied on karyotyping of products of conception. Then we went on to doing FISH testing for quick trisomies. And of course, for the 5 or 7 chromosomes, this is a very quick, inexpensive, and very reliable method for trisomy detecting. However, we cannot study all the chromosomes by FISH. So we come to the recommended tests for products of conception, which is CGH microarray. The advantage of CGH is that you don't need viable tissue at all. So anyone who's had a miscarriage for nearly 4 weeks, even somebody who dropped the products in the toilet bowl and then fished it out for you to see, these products can also be sent for CGH because you don't need live tissue. And the other advantage is there is no maternal cell contamination. And you can even pick up defects which are smaller than big chromosomal defects like single gene defects. But what is most exciting is next generation sequencing. And this is actually round the corner, will be available soon more widely, but that will take away maternal cell contamination completely and give you even single nucleotide polymorphism analysis of the products. So the take-home message for genetic testing is all products of conception after the second miscarriage should have genetic testing by CGH microarray. Then we come to whether we should test all the parents for a carrier state. And here we look at the evidence for translocations. Of course, balanced translocations are much higher among couples that have RPL, 2 to 5%, than the general population, which is 0.2%. And pre-implantation genetic screening in age-matched populations shows that embryos with RPL women have a higher incidence of aneuploidy. But if we test all parents of RPL for karyotyping or studying their chromosomes, we waste a lot of their precious resources. So although we know that this kind of Robertsonian translocation in the male or a balanced translocation in the female can be seen in couples with RPL, the guidelines say that we should test the parents only if the products show an abnormality. So most genetic defects, So if your products of conception, which is the first point of genetic testing, shows abnormality, we do go ahead and test the couples and see if this abnormality is arising de novo in the products or it is being passed on by the parents from the mother or the father. So we also know that now single gene defects have come up in a big way in RPL, and these can only be picked up by CGH microarray. When we do genetic testing, our genetic counseling is most important. The good thing about genetic testing is that it offers an explanation for the cause of miscarriage, and that takes away the maternal stress to a great degree. But we must also remember that we need to give a very positive genetic counseling, because most genetic defects that are not carried by the parents will autocorrect in a subsequent pregnancy. So her outlook for having a normal pregnancy next time is much higher if she has a genetic abnormality in the products of conception than if the POCs are normal. So the benefits of doing is that if you have an abnormal products of conception report, you will screen both the parents and you will be able to detect balanced or reciprocal translocations, and you will be able to offer a cause for the miscarriage to the mother. Maternal errors are also responsible for many cases of abnormal embryos, and especially the sex chromosome trisomies come from the sperm. So it is important we test the sperm, and we will come to that in a minute. So to sum up your genetic testing guidelines, the ESHRE guideline, which is the latest on this subject in 2017, said parental karyotyping is not routinely recommended in couples with RPL. And then the ACOG practice guidelines in 2019 said that CGH microarray testing of fetal tissue is necessary in patients with more than 2 pregnancy losses of less than 20 weeks gestation. So I think this point is quite clear to all of you. And if this is clear, we go on to the next subject in a minute. I can skip this, and we can go on to seeing whether we need to do sperm DNA fragmentation in couples with RPL. Now, sperm DNA fragmentation is done by direct methods and indirect methods. And the good news is that for those of us who thought it was a very complicated assay, in 2019, there has been a case report, there has been a publication which says that aniline blue dye and toluidine blue staining will pick up abnormal sperms or those with high DNA fragmentation by a simple staining method. So the test is going to get simplified very soon. But currently, we look at this DNA fragmentation index, and if you see a normal sperm and you look at this picture, the normal sperm looks somewhat like this, like the first picture. If there is low DNA fragmentation, there is some dispersion of DNA. If there is moderate, there is more dispersion, and if there is severe, there is a long tail or the comet. And in another test, you can look for a halo around the sperm. So the one that is normal shows no halo, and the one fragmented shows a big halo. So there are many publications which say that sperm DNA fragmentation is recommended in recurrent implantation failure and RPL, but it is currently not widely accepted as part of the workup. However, very soon we are going to include it in the workup of RPL. When you have a genetic problem, of course, you can think of gamete donation, you can think of PGS, IVF, but it is important that we make a routine to do the CGH microarray on the products of conception. Coming to the new developments in the field of infection, of course, you're all aware of bacterial vaginosis and asymptomatic bacilluria, but I want to draw your attention to subclinical endometritis and the uterine microbiome. And there are these papers coming up from 2019 and 2018 that have been studying the uterine microbiome in RPL. And they have said that there is dysbiosis with lack of lactobacilli in the 20 RPL cases that they studied versus the 10 controls. And so it is important that we recognize that there is an emerging role of probiotics to correct the uterine microbiome in patients who have infections. And lastly, I wanted to cover the new research in the field of autoimmunity. I had always felt that patients that have any autoimmune disorder have a higher incidence of miscarriage because their uterine environment does not function as it should function at the time of implantation. And for this, I used to ask a detailed history from my patients of rheumatoid arthritis, uveitis, vitiligo, skin lesions, alopecia, celiac disease, any other autoimmune disease. And there was a paper which said that miscarriage rate is 28% in autoimmune positive group versus 14% in the control group. But we didn't know what is the best test to do. And although ANA titer we did, but we also were doing double-strand DNA, AMA, smooth muscle, and parietal cell antibodies. But this very recent meta-analysis by Chen, which came out August 2020, which is just this month, they studied 21, they included in their meta-analysis 21 studies with 5,000 patients, of which 2,500 had RPL and the rest were controls. And they found that in the RPL group, 22% were ANA positive, but in the controls, only 8.3% were ANA positive. And this difference was clinically significant. And they took the cutoff of ANA positivity as being 1 in 160, should be more than 1 in 160. So if somebody has a low ANA theta, less than 1 in 160, you can just repeat it or ignore it, but don't classify it as autoimmune. And another beautiful meta-analysis, exactly on the same lines, published in July 2020, they looked at 7 case control studies of 1,400 patients of RPL and 1,000 controls. And they found similar results, that ANA was positive in 20% in the RPL group and 6.7% in the control group. So both these studies point out that ANA can be an important test that we should include in our patients of unexplained RPL. And lastly, I wanted to take you through this meta-analysis on antithyroid antibodies and recurrent miscarriage. This meta-analysis also came out in July 2020. They looked at 20 studies that had antithyroid antibodies positive and had recurrent miscarriage. And they found that TPO antibody positive patients had a higher rate of recurrent miscarriage. And also the TPO antibody positive patients had higher TSH values. And live birth rates were improved with thyroxine supplementation. So far, there has been some ambiguity with the antithyroid prescribing L-troxin to women that have normal TSH but positive antibodies. But here comes this meta-analysis which says if you're trying for a pregnancy and you have positive antithyroid antibodies but normal TSH, please prescribe them thyroxine for a better outcome. Again, July 2020, and I think this July-August has been a very exciting period for me in RPL because I'm seeing such good new research. This paper came out from Japan, and they said that in their women of unexplained RPL, they studied new autoantibodies, which were beta-2 glycoprotein 1 HLA-DR-COM antibodies. And many women that were otherwise unexplained had these antibodies positive. So they did not have APL antibodies, but they called them neo autoantibodies. And these antibodies also lead to thrombosis, just like APL syndrome, and they required anticoagulation. So having discussed all the new research in this field, let us look at the treatment options we have. And what caught my attention was, when we looked at this high incidence of autoimmunity, we know that there are 5 antigenic foods which actually accelerate autoimmunity in our body. And these antigenic foods are eggs, meat, soybean, peanuts, and dairy. And when you talk to functional medicine specialists, they deal with patients of autoimmunity that are on high doses of steroids and still not being benefited. And all they do is cut off the antigenic foods from their diets, and which is what we call a vegan diet. Now, to understand how that helps, I read more about it, and it says that undigested protein molecules, and you can see that all these antigenic food are actually proteins. So undigested protein molecules may be absorbed by any breach in the gut mucosa, and they are then presented to the systemic circulation. And when a protein molecule is presented to the systemic circulation, they evoke an antigen-antibody response in the body. So if there is even mild autoantibodies somewhere, they get boosted by eating antigen-rich food. So first and foremost, for autoantibodies, we come back to probiotics. Fix the gut, make sure there is no gut infection, make sure that the gut flora are healthy, and so you can prevent absorption of protein molecules. You can put them on a vegan diet, and that also helps. And after you have done all that, you can look at treatment options like IVIG. And IVIG has shown to work in autoimmunity with RPL. And this was a paper published by Dr. Christiansen, that if you give IVIG to women who have SLE, other autoimmune diseases, and secondary RPL, they have a higher live birth rate. IVIG is also indicated in women who have antiphospholipid syndrome, but if they still miscarry after you have given them aspirin or heparin. But can we give IVIG to unexplained RPL? And the answer is no, because there was a very good single center, double blind, randomized controlled trial in Denmark, where they took 82 women with unexplained RPL, more than 4 miscarriages, and they gave them IVIG versus plain albumin infusion from the date of positive urine pregnancy test to 15 weeks. And the live birth rate was 54% in the IVIG group and 50% in the placebo group. So it is certainly not recommended for the unexplained group. And the same guidelines follow for intralipids. Steroids are recommended if you have high natural killer cells in the endometrium in the presence of autoimmunity. And GCSF does not actually have a role in autoimmunity, so I will skip that and take you to this next exciting molecule, TNF alpha blocker. So one of them is etanercept and the other is adalimumab. So these are TNF alpha blockers that are given by a subcutaneous dose, and this one is given every 1 to 2 weeks, but they have to be started 1 month before initiating an IV, before initiating a pregnancy or an IVF cycle, and you stop them as soon as the fetal heartbeat is seen. And this is the study I could find for this, published in the American Journal of Reproductive Medicine in 2008. They had 75 pregnancies with RPL, and they divided them into 3 groups. One, they just gave heparin, and they got a 19% live birth rate. To the second group, they gave heparin plus IVIG, and they got a 54% live birth rate. And to the third group, they gave heparin plus IVIG plus etanercept plus adalimumab. So these were obviously more difficult patients to treat, and they got a 71% live birth rate. So in your patients who have autoimmunity, it is worth considering TNF alpha blockers. And to conclude my talk, I want to take you through to some more new exciting developments. One is the role of stem cells and platelet-rich plasma. And this is not yet come up front in the clinical setting, but there have been publications since 2016 saying that this will improve the decidual uterine natural killer cell environment. And lastly, sitagliptin for recurrent pregnancy loss has been mentioned in UpToDate in January 2020. It is shown that sitagliptin, which is an anti-diabetic drug, increased the endometrial mesenchymal stem cell population compared to placebo. And so, even though it seems like a promising treatment, we must wait for adequately powered clinical trials before we prescribe it for this indication. So with that, my take-home message is that genetics involves testing the products of conception with CGH microarray and parental karyotyping subsequently, and ANA testing will become a part of the RPL workup soon. Thank you very much.
Thank you, Dr. Mala, for really a very crisp and a clear evidence-based newer concept in the RPL, and especially talking about the probiotic role in concern to the autoimmunity and the role of a TNF alpha blocker. We all know, hello?
Yes.
We all know that this very frustrating field of RPL, especially for the clinicians and the patients. And most of the time is frustrating because we fail to give the clear answer, or we are landing the patients in a non-evidence based investigations and just roaming around that. It really becomes very difficult for the next clinicians to explain what is going around. So you have really given the very nice insight about what is newer development and their evidences. Thank you for a very nice presentation, Dr. Mala. I'll request Dr. Tushar to take up the second speaker.
Dr. Mala, congratulations for your excellent presentation, and we know many new things. I would appreciate about the diet and the vegetarian diet in that field. I think I will also have a good experience of special diet, which was old time prescribed by Ayurvedic, and that is also giving a very good result. I will
Yes.
just tell it at the time of discussion.
Okay.
Now, next speaker is Dr. Amit Padki. I think he do not need any introduction. He is a very well-known figure in Foxy and all over obstetric field of India. At present, he is honorary associate professor at Somaya Medical College and medical director of Fertility Associate, which is a center for assisted reproduction technology. He has, to his credit, more than 35 scientific publications and several book chapters to his credit. He has won several awards at national and international levels. He received Foxy Korean Award in 2003 for Best Research in India. He also received EOFOG Young Gynecologist Award in 2005 at Seoul. Dr. Amit Padki, please take on. And he is going to speak on alloimmune aspect of recurrent pregnancy loss.
Thank you very much to Foxy. Hello. Thank you very much to Dr. Alpesh Jotade, Dr. Vidya Tobi, for having me in this wonderful CME on recurrent spontaneous miscarriage. I think Dr. Mala has set the field, and I will be speaking on the autoimmune cause for recurrent spontaneous miscarriages. Now, we all know that whatever we see is just the tip of the iceberg. As Dr. Mala has rightly said, 90% of the pregnancies are lost even before the patient would know that she's pregnant, and around 70% of conceptions are lost prior to live birth. We know that the spontaneous miscarriages occur in approximately 15 to 18% of all clinically recognized pregnancies, and it could go up to as high as 45% after 3 consecutive miscarriages. And I think ASRM has taken the right step of diagnosing or labeling somebody with recurrent spontaneous miscarriages after 2 miscarriages, because that way you can initiate investigations and offer them proper treatment. We know that there are consequences of threatened miscarriages, including anxiety, depression, stress. And to add to that, there is poor obstetric and perinatal outcomes because of increased incidence of antepartum hemorrhage, preterm labor, preterm delivery, IUGR, and low birth weight babies. And in patients with recurrent miscarriages, the stress levels and the anxieties are multifold. As far as causes for recurrent miscarriage are concerned, there could be around 50 to 60% of causes which could be explained, as Dr. Mahala has taken us through the armamentarium of genetic infections and partly in newer concepts of autoimmune. And Dr. Manju will take us through other prothrombotic regions, but there are another 40 to 50% which are unexplained causes, and they could fall in the ambit of alloimmune causes, where we think that there is deficient immunosuppression with an increased maternal Th1 cytokines, giving rise to a decrease in the maternal Th2 cytokines. A very beautiful review article in 1999 which said, "Why did your mother reject you?" looking at all the immunogenetic determinants of the response to environmental selective stress, which is expressed at the uterine level. Now, when we talk of maintenance of early pregnancy, there is a large amount of orchestration of various hormones and immunoglobulins, including interleukins, cytokines, which cause the pregnancy to implant and then grow and then have a viable pregnancy. Now, what are these cytokines? These are secreted molecules that regulate the intensity and duration of the immune response by exerting a variety of effects on lymphocytes and other immune cells. The cytokines are messengers of the immune system, like hormones are the messengers of the endocrine system. Now you have some good cytokines and some not so good cytokines. The Th1 cytokines which are released, which are the interleukins 2 and the TNF alpha, will cause microthrombi and rejection of the pregnancy, and a Th type 2 response with release of interleukins 4, 6 and 10 will cause a conducive environment for the pregnancy to implant and continue. So cytokines are not necessarily always the bad cytokines. You have even the good cytokines. Now what happens when there is a Th1 cytokine response? It triggers a thrombotic or an inflammatory processes at the maternal uteroplacental blood levels by activation of the vascular endothelial cell procoagulant. The Th type 2 cytokines inhibit this Th1 induced destruction by monocytes. The TNF beta is supposed to suppress the growth of the trophoblast by inducing apoptotic changes in these cells. So when you have microthrombi inflammation at the site of implantation, it is not conducive for growth of the embryo, and this generally will cause very early miscarriages. As far as hormones in pregnancy and the luteal phase is considered, the progesterone is the only hormone which rises through all the 3 trimesters of pregnancy. The HCG, which we consider as the hormone of pregnancy, also starts plateauing out at 14 to 16 weeks. So when you see low levels of progesterone, these are generally associated with recurrent miscarriages. So is progesterone the missing link? I would consider yes in the alloimmune section because it affects implantation, pregnancy. It also is known to reduce the immune response of the mother to allow a foreign body, the embryo, to be implanted and continue to grow till the progesterone levels start dropping down in the 3rd trimester, which we know is sometimes an initiation of labor. Now, we can also monitor the pregnancies by uterine artery Doppler. This becomes another non-invasive method to evaluate uterine perfusion because the uterine perfusion will regulate endometrial receptivity and inflammation. And an inadequate perfusion leads to implantation failure or is detrimental to uterine development. So in cases of recurrent miscarriages and uterine artery flow, the impaired impedance to the uterine blood flow in recurrent spontaneous miscarriages, you have higher PI pulsatility index than normal fertile women, and this impaired perfusion could be one of the causes for unexplained infertility or unexplained miscarriages or implantation failures. So there is a very good paper which saw a correlation between pulsatility index and other factors, and you can very well see that barring the age and the progesterone, which showed statistical significance to increased PI values, rest, whether it was the hormonal levels or nitric oxide level or even the endometrial thickness, was not correlated with pulsatility index, and that's why progesterone is some hormone which affects immunomodulation. As I said earlier, there are 2 types of responses that you would get in early pregnancy: the Th type 1 cell response or the Th type 2 cell response. And depending on which response is the predominant response, if you have the Th1 response, which is predominant, you would have an unconducible environment and inflammatory thrombotic environment at the site of implantation, thereby causing abortion or non-implantation of the embryo. And if you have a type 2 response, it is immunoprotective or an embryo protective response. So what exactly happens in this Th type 1 response? There is release of these symmetric antibodies which bind with the paternal antigens and maternal antibodies, causing activation of the complement cascade. And what is the complement cascade? It is T helper type 1 response which is activated. The TNF alpha and the interleukins 2 get stimulated. The natural killer cells are activated. The lymphokine activated killer cell thereby causes miscarriage. How can you prevent this cascade reaction? This is by a release of an enzyme which is the PIBF, which is the progesterone induced blocking factor, which causes blocking of this cascade reaction because of release of asymmetric antibodies, and this causes immunoprotection. Now this is a three-pronged response. You have asymmetric antibodies, hence no binding with the antigen and no activation of the complement cascade. The other thing the PIBF does is it reduces the activity of the natural killer cells. And the third thing this PIBF does is release of these good or these protective cytokines, which is interleukins 4, 5, 6, 10, and 13, thereby a tripod or a tri response will cause protection. So when there is release of these symmetric antibodies, it binds with the antigen, giving you a complement cascade or a cytotoxic or a phagocytic response, which is predominant with TNF alpha, interleukins 2, 12, and 18. And when there is an asymmetric antibody, there is release of these good interleukins, which is 4, 6, 10, and reduction in the natural killer cell activity. Now, where is this PIBF released? It is produced by the CD56 cells, produced after activation of these progesterone receptors, supports Th type 2 response, reduces activity of the natural killer cells. Various in vivo tests done by Bartho and published in early 2000 has shown that when PIBF is adequately released, there is normal progress in pregnancy. When the PIBF is artificially reduced in these mice cells by addition of RU486, it causes a Th1 response and a miscarriage. And when you add anti-PIBF to these cells, it again causes a predominant Th1 response. So when you look at PIBF concentrations, which unfortunately are still not available commercially, we see that when there is a very low PIBF levels, these are the patients which come not only with recurrent miscarriages, but also with threatened preterm labor. And when there is adequate levels of PIBF in the women through the pregnancy, their delivery happens closer to term when the PIBF naturally starts coming down. Now, as I said, progesterone is not only a hormone, it is also an immunomodulator because it releases this PIBF, which indirectly causes immunomodulation. So we know that in studies which have been done, progesterone favors the development of the human T helper cell type 2 response and promotes interleukin 4 production. There was a very excellent paper which was published early 2013, which measured the Th type 1 cytokine response in patients with recurrent miscarriages and with multiple implantation failures after IVF. And as you can see, there is a statistically significant increase in the Th type 1 response in these patients of recurrent spontaneous miscarriages and multiple implantation failures as compared to the controls. Although this study had small numbers, but we know that this could be maybe if done in multicentrics, we could have seen it. Now, when you look at studies, meta-analysis and guidelines, there is plenty of literature in the domain which shows that there is a significant reduction of miscarriage by progestogens versus placebos or no treatment. But CARP in 2015 separated these various different papers from and separated the micronized progesterones from the dydrogesterone and found that when you look at dydrogesterone specifically, you find that there is significant reduction of miscarriage as compared to standard care alone. And the 2015 European progestin guidelines suggest that in patients with recurrent miscarriages, the form of treatment would be dydrogesterone. Now, we had two excellent studies which were published one after the other. The PROMISE trial of 2015 versus Kumar study, which was released in 2014. And both of them looked at patients of recurrent miscarriages, the PROMISE trial treating with micronized progesterone, and Kumar study treating with oral dydrogesterone. And we find that the Kumar Swami study of PROMISE was a multicentric trial, whereas the Ashok Kumar study of 2014 was a single center trial. Both had adequate number of patients, but when you look at the efficacy results, you found that the live birth rates were not significantly increased in the micronized group as compared to the placebos, and that really did remove the promise from the PROMISE trial, whereas the Kumar study of 2014 showed that with use of dydrogesterone, the miscarriage rates were significantly reduced with the use of dydrogesterone. Now, although the PROMISE trial had a large number of deficiencies in the initiation and conduction of trial, but this really put dydrogesterone as a drug of choice for recurrent miscarriages. Now, what are the other therapies? And Dr. Mala has taken us through some of these immunotherapies, but I will look at this paternal cell immunization or third-party donor leukocytes, which have been used in the past, and they always have a bit of a surge in certain centers. But frankly, there is no good meta-analysis or Cochrane data to suggest that they have a significant beneficial effect over placebo. Although I know there are centers, not only in India, but abroad, which are working very hard and showing very promising results with paternal cell immunizations. When you look at IVIG, I think Mala has already shown this slide, which shows that you could give it indicated in patients when miscarriages occur, despite the patient being on aspirin and heparin. Intralipid, again, I'm not very comfortable to treat with patients of RPL, but it has also been used in recurrent implantation failures. So to summarize, alloimmune progesterone is the only drug of choice when you want to use it. It is the mechanism is through the progesterone induced blocking factor, which shifts the to Th type 2 response. And Ashok Kumar study, which has been done in India in a single center, has shown significantly increased pregnancy rates reaching statistical significance, and CARP's meta-analysis has also shown that dydrogesterone is the drug of choice as compared to placebos, and the PROMISE trial failed to give us the promise of micronized progesterone in recurrent spontaneous miscarriages. Thank you very much for a patient hearing.
Dr. Amit, thank you very much for enlightening us in the field of alloimmune causes of RPL. You have very clearly make us understand how it occurs, and actually the progesterone is the only answer to that treatment. I request Dr. Sanjay to introduce Dr. Manju Puri and
after very interesting talk of Dr. Amit and initiation of this webinar by Dr. Mala, now we have with us Dr. Manju Puri. She'll be talking on the post-thrombotic states in RPL. Dr. Manju Puri, just share her PPT, Dr. Manju Puri.
Yeah, I will.
Dr. Manju Puri, yes. I'll just wait for the PPT to be here.
Is my
She's
screen
a senior
visible?
faculty member at Delhi. Just wait for the director and the professor and head of the obstetrics and gynecology of LHMC New Delhi. Yes, this is the bio sketch of Dr. Manju Puri. She is presently the chairperson of the Quality Improvement Committee of AOGD, awarded the CS Dong Prize with the CL Javeri and Shrimati Bhagwato Yamuna Singh Prize by the Foxy. She has also delivered the Suman Kher Oration and the Shrimati Leelavati Orations, awarded ICOG Foreign Fellowship and the WHO Fellowship. Member of National Mentoring Group for the Medical Colleges for Lakshya Implementations, National Felicitator of Adolescent Health and Quality Improvement. She is also the Subject Expert Committee at the Central Drug Standard Control Organizations and the Principal Investigator of Niti Aayog-led Healthcare Artificial Intelligence Catalyst Project. More than 100 publications and 1100 citations. She has also edited books on anemia in pregnancy, management of high-risk pregnancy, practical approach, and the clinical methods in obstetrics and gynecology. With this, now Dr. Manju Puri is going to talk on the states, thrombotic states in RPL. Dr. Manju Puri.
Thank you, Dr. Sanjay, for your kind introduction. And thanks to Dr. Vidya for inviting me for this talk today. And after two very, very interesting and informative talks by Dr. Mala and Dr. Amit, I will now take you through this topic of prothrombotic states in RPL, evidence-based management. Is my screen visible?
Yes, dear Manju.
Yes.
All right. So, we all know that prothrombotic states or thrombophilia are conditions that predispose an individual to thrombosis or formation of clots. And they do have a role to play when we talk about recurrent pregnancy losses. So these conditions can be either inherited or acquired. Inherited conditions would include factor V Leiden mutation, prothrombin gene mutation, antithrombin deficiency, protein S deficiency, and protein C deficiency. Whereas the acquired conditions would include antiphospholipid syndrome, which could be primary or which could be secondary. It is usually secondary to diseases, autoimmune diseases like SLE. Now, looking at the association of recurrent pregnancy loss with inherited thrombophilia, the association is controversial. Prospective studies have found no association, whereas retrospective studies have found modest association. Routine screening of women with RPL for inherited thrombophilia in the absence of any thromboembolic episode is not recommended. Treatment of women with RPL and inherited thrombophilia by prophylactic anticoagulants have not shown any significant benefit as far as pregnancy outcomes is concerned. This was a study which we conducted way back from 2006 to 2010. And this is to show you that thrombophilias per se in Indian population are much lesser as compared to the Caucasians. So in this study, we looked up all the patients with pregnancy complications, and we found that prothrombin gene mutation is not does not exist in our population. That mutation was found amongst the cases, but it was had less than 4% in the population amongst all the complications. MTHFR mutation, which is considered to be thrombogenic, was found more among the controls compared to cases. So this is not a significant mutation as far as Indian population is concerned. We also found that vegetarianism was found to be significant risk factor for a lot of pregnancy complications. So for our population, it is only factor 5 laden mutation, which can have a role, but a very small role as compared to the Caucasian population. This was another study which we had done, in which we found that MTHFR polymorphism, folate, and vitamin B12, and we tried to correlate all these with homocysteine in patients with recurrent pregnancy loss. So we had 107 cases and 343 controls. They were subjected to plasma homocysteine, serum B12, and serum folate levels, and we also looked for MTHFR mutations in both cases and controls. What we found that our patients are majority of our cases were folate replete, and folate deficiency was more common in controls, that is those who were who did not have recurrent pregnancy loss compared to those who had recurrent pregnancy loss. It was vitamin B12 deficiency which was more common in cases, and hyperhomocystinemia was definitely more common in cases. Thereby, we interpreted that it is more of vitamin B12 deficiency which could be causing to hyperhomocystinemia, which itself is considered to be thrombogenic in nature. However, there was no difference in the distribution of MTHFR mutation in both the groups, but we observed that all those cases who had MTHFR mutation had higher levels of homocysteine in the presence of vitamin B12 deficiency. Now, looking at acquired thrombophilia and recurrent pregnancy loss, antiphospholipid syndrome, both primary and secondary, are associated with RPL. So much so that RPL is one of the clinical criteria to diagnose antiphospholipid syndrome. In women with RPL, 5 to 15% may be positive for antiphospholipid antibodies. And in the antiphospholipid workup for women with RPL, assessment of anticardiolipin antibodies, IgG and IgM, lupus anticoagulant, and anti-beta-2 glycoprotein 1 antibody, both IgM and IgG, is indicated in all women with RPL twice 12 weeks apart. Treatment of women with RPL and antiphospholipid syndrome by prophylactic anticoagulants significantly improves the pregnancy outcome. So this was a study in which we looked at anti-beta-2 glycoprotein and anti-prothrombin antibodies in patients with unexplained recurrent pregnancy losses. We took 50 patients of recurrent pregnancy loss and 50 controls. And what we found was that 22% women were positive for APL antibodies compared to none in the control. And out of this, interestingly, only 2 were positive for lupus anticoagulant. There were 6 for anti-beta-2 globulin, and 1 for anti-cardiolipin antibodies, and 3 for anti-prothrombin antibodies. Meaning thereby that anti-beta-2 microglobulin is an important test which should be carried out when we are wanting to rule out antiphospholipid antibody syndrome. Now, how do these antiphospholipid antibodies relate to recurrent pregnancy loss? So the main effects of antiphospholipid antibodies are on the placenta. So they cause uteroplacental thrombosis and vascular insufficiency. They also have a direct adverse effect on the function of placental trophoblast, and they decrease its viability and invasive properties. They affect the production of hormones, and they induce inflammatory response in placental tissues as in other autoimmune diseases. So it is basically anti-beta-2 glycoprotein antibodies which react with trophoblast and inhibits its proliferation, differentiation, and induction, and induce apoptosis. So how do we diagnose antiphospholipid syndrome? So the updated Sapporo criteria says that at least one clinical and one laboratory criteria has to be fulfilled. And in the clinical criteria, there can be history of vascular thrombosis, one or more clinical episodes of arterial or venous thrombosis, and the second clinical criteria is pregnancy morbidity. So one or more unexplained death of a morphologically normal fetus after or equal to 10 weeks of gestation, and one or more premature birth of less than or equal to 34 weeks due to preeclampsia or uteroplacental insufficiency. And uteroplacental insufficiency may be evident by either Doppler flow changes or oligoamnios or FGR, and 3 or more unexplained consecutive spontaneous abortions before 10 weeks. So if we look at this, recurrent abortions would form an important clinical criteria for labeling a patient of antiphospholipid syndrome. One out of these, the clinical ones, and one out of the laboratory criteria. And in the lab criteria, it is presence of lupus anticoagulant on 2 or more occasions 12 weeks apart, and presence of anti-cardiolipin antibodies in medium or high titer on 2 or more occasions 12 hours apart, and presence of anti-beta-2 glycoprotein 1 antibodies, again, on 2 or more occasions 12 weeks apart. Remember, abruption is not a defining morbidity for antiphospholipid syndrome. So it has to be one of these, either preeclampsia, early onset preeclampsia, or uteroplacental insufficiency, or 3 or more consecutive abortions before 10 weeks, or one abortion after 10 weeks in a morphologically normal fetus. So how do we go about treating a woman with RPL and antiphospholipid syndrome? The mainstay of treatment is anti-thrombotic therapy. It has to be a combination of anticoagulation and aspirin. We have to carefully monitor the mother and the pregnant woman and the fetus for early detection and timely intervention of complications, because these women are predisposed to hypertensive disorders of pregnancy, to FGR, and to oligohydramnios. A scheduled delivery at 38 weeks or earlier if indicated. We need to stop aspirin 7 to 10 days before the delivery and switch the woman from low molecular weight heparin to unfractionated heparin prior to planning her for a delivery. And normally we would do it at 36, 37 weeks. And we stop unfractionated heparin 6 to 8 hours before delivery. The reason why we need to switch them from low molecular weight to unfractionated heparin is because low molecular weight has got a longer half-life as compared to the unfractionated heparin, and we have an effective antidote of unfractionated heparin available. In the postpartum, we need to keep these patients on thromboprophylaxis. So what antithrombotic treatment do we need to give them? So low dose aspirin, 150 milligram per day, is what is desirable. It can be started when the patient is trying to conceive. So it can be started prior to her being pregnant, and it can be stopped anytime after 36 weeks, usually 7 to 10 days before the planned delivery. But you can stop it at 36 weeks. Anticoagulants are to be started once the pregnancy is confirmed, and heparins are preferred as they do not cross placenta and do not cause fetal anticoagulation. This is as compared to warfarin, which has its own teratogenic effects, especially when used in doses of more than 5 milligram per day. Low molecular weight heparin is preferred to unfractionated heparin, except near term. And anticoagulants, warfarin is avoided as it is teratogenic and crosses placenta. And non-heparin oral anticoagulants, danaperoid, can be used only for women with heparin-induced thrombocytopenia or inability to administer injections. So most of our patients would go on low molecular weight heparin, one dose, 40 milligram subcutaneous every day. So if we look at the dosage, we have to decide whether it's a prophylactic doses or it is a therapeutic dose. We have to give the anticoagulant therapy in. So in pregnant women with RPL and antiphospholipid syndrome without prior thrombosis, there's no history of prior thrombosis, we give them prophylactic dose, that is enoxaparin 40 milligram or dalteparin, 5,000 international units subcutaneous once a day. And because low molecular weight heparin is costlier, so in case the patient cannot afford, we can give an unfractionated heparin 5,000 international units subcutaneous every 12 hours. If we have to give it in therapeutic dose, in pregnant women with RPL and antiphospholipid syndrome with prior thrombosis, we need to give them enoxaparin in the dose of 1 milligram per kg or deltaparin in the dose of 100 international units per kg, subcutaneous every 12 hours. So we give it twice a day. And if it is unfractionated heparin, then it has to be given in the dosage of 250 units per kg every 12 hours. And if she's on unfractionated heparin, we need to keep the APTT in therapeutic range of 1.5 to 2.5 times the normal. How do we monitor these mothers now? All women should have a baseline hemoglobin, hematocrit, platelet count, and baseline serum creatinine. We need to do a repeat platelet count in women on heparin, and women on prophylactic dose of low molecular weight heparin or even unfractionated heparin. We do not require a regular monitoring. But those who are on therapeutic dose, for low molecular weight, no specific monitoring may be done, but some would monitor them by anti-factor 10A activity 4 to 6 hours after the last dose to maintain it between 0.6 and 1 unit per ml. Whereas with unfractionated heparin, we need to monitor it by APTT 6 hours after the last dose and maintain APTT between 1.5 to 2.5 times. We monitor every day till the target is reached, and then we need to monitor it every 1 to 2 weeks. Unfractionated heparin is preferred to low molecular weight heparin, and more intensive monitoring is indicated in women with diminished renal functions. So if a woman has got diminished renal functions, I said that patients with SLE can also have secondary APLA. So in those cases, we need to think of unfractionated heparin as prefer unfractionated heparin compared to low molecular weight heparin. Now, what do we do with these patients in labor and delivery? So we would not give any anticoagulant therapy during labor. So low molecular weight heparin is switched to unfractionated heparin at 36 to 37 weeks or earlier if there is risk of preterm delivery. And protamine sulfate is a antidote to unfractionated heparin. We would give 1 milligram to neutralize 100 international units of unfractionated heparin. And it is given as a slow IV infusion, not to exceed 20 milligram per minute, and total dose not to exceed 50 milligram in 10 minutes. Remember, one should keep in mind when did the patient receive the last dose of unfractionated heparin? Because if you overcorrect, protamine sulfate itself has an anticoagulant effect. So if the patient has received the dose, say about 4 to 6 hours prior to you deciding to neutralize it, then one would give much lesser dose as compared to a full dose. Unfractionated heparin stopped once spontaneous labor starts and 12 to 24 hours before planned induction of labor or cesarean section. So we need to stop the anticoagulants. If she's on unfractionated heparin, we would stop it as soon as the labor starts. And in case we are planning for induction of labor or cesarean section, then we would stop it 12 hours in case she's on prophylactic regime and 24 hours before in case she's on therapeutic regime. Neuraxial anesthesia, spinal or epidural can be performed 12 hours after prophylactic low molecular weight heparin and 24 hours after therapeutic low molecular weight heparin. This is to avoid the risk of hematoma formation. The anticoagulation can be reinitiated 6 to 12 hours after vaginal delivery or 12 to 24 hours after cesarean section for postpartum thromboprophylaxis, both low molecular weight and aspirin for 6 weeks postpartum. Now, what complications can happen with anticoagulants? First, about heparin, there can be bleeding. So in case patient has any bleeding problem, there can be neutralization done with protamine sulfate. And the second is heparin-induced thrombocytopenia. It is rare and it is usually seen with unfractionated heparin. So we need to stop heparin and switch the patient onto other non-heparin anticoagulants. And heparin-induced bone loss. That is also common with unfractionated heparin. So we need to give regular calcium and vitamin D supplements to the pregnant women and ask them to carry on with the weight-bearing exercises. A word about hydroxychloroquine, and this is another drug there are a number of patients who, despite being receiving aspirin and anticoagulants, would still abort. So do we have anything else for them? Dr. Mala had talked about blockers, but hydroxychloroquine is another drug which can be given in the dosage of 200 to 500 milligram daily, starting 3 months prior to pregnancy. And in women with antiphospholipid syndrome, it has to be given only in women who are confirmed cases of antiphospholipid syndrome. It actually depresses the antiphospholipid levels. However, there is limited evidence to support its use. So if you do not have anything, then maybe this is another drug which can be used. So to summarize, association of RPL with antiphospholipid syndrome is well established. Association of RPL with inherited thrombophilia is controversial. Diagnosis of antiphospholipid syndrome is made in the presence of one clinical criteria and one lab criteria. Persistence of antiphospholipid antibodies is important, and treatment of pregnant women with RPL and antiphospholipid syndrome without prior thrombosis, without history of prior thrombosis, we need to give them a prophylactic dose of low molecular weight heparin plus low dose aspirin 100 to 150 milligram throughout pregnancy, starting aspirin before conception and low molecular weight once the pregnancy is confirmed by UPT. Treatment of pregnant women with RPL and antiphospholipid syndrome with prior thrombosis, we need to give them therapeutic dose of low molecular weight heparin plus low dose aspirin 100 to 150 milligram per day throughout pregnancy, starting aspirin before conception and low molecular weight once the pregnancy is confirmed by UPT. Antithrombotic treatment is not recommended in pregnant women with RPL and inherited thrombophilias and women with 2 or more miscarriages, but without APLA or thrombophilia. I know most of us would give it thinking that there is nothing else which we can do, but then, well, we need to clarify to the patient that it is all empirical and it does not have any robust data to support it. So thank you so much for patient hearing. So these are guidelines which I have referred to.
Yes, yes.
Thank you, Dr. Manjupuri, for such an elaborate talk on the antiphospholipid syndrome. It's a very clear guideline about the diagnosis and the management with the anticoagulants, and very clear message about the inherited thrombophilia as it has no role or is a very controversial. Thank you for a lovely clear-cut message at the last. With this, we come to the end of the 3 history award talking about the RPL, Dr. Amit Patki, Dr. Mala Arora, and Dr. Manjupuri. And now the session is open for the question and answers. And hand over to the Vidyathobi because I have to rush to the OT. Sorry for starting early.
Yes.
It's really enjoyed all the 3 speakers. Absolute clear message, very clear, and the crisp slides. Really enjoyed all the 3 talks. Thank you. Thank you for everything.
Thank you. Thank you very much for joining. Sana, just any questions are there on this RPL? Any viewers? I must say that this was a very successful webinar. More than 600 people are viewing this webinar right now. And definitely they are enjoying this webinar with the people who are talking are the stalwarts in the subject, and it was very simplified and reached everyone. So, Sana, if there are any questions, can you put forth in the chat box?
Yes, madam, I'll do that. I'll check.
Yeah,
I'll put
please
the
put
questions.
up or to put up to me.
Yeah.
So there were questions like, what is the opinion of the panel on the use of steroids? That is my question. Many of them, I have seen the people treating this patients with steroids.
Can I take that question for you?
Yeah.
So, number one, steroids are absolutely contraindicated in antiphospholipid syndrome.
Yeah.
And that has to be remembered very clearly.
Yeah.
Only for a long time, steroids were not indicated in RPF for any indication.
Yes.
Very recent studies are saying that women that have a high natural killer cell count in the endometrium. So you can study that by doing a pipelle biopsy of the endometrium 7 days post ovulation. and then you study it by flow cytometry, which is an expensive test. And so far it is a research tool, but this test will come to the clinical armamentarium very soon. Already in Delhi, it is available. I've done it on 2 of my patients. Dr. Lal's Math Lab does it. But it needs more standardization. It is still in its initial phases. But those women that have very high natural killer cell count, and that is what Dr. Amit was talking about, disturbed cytokines, you have 2-3 options to treat them. The first and the simplest is steroids. Then is, of course, IVIG, and then is TNF alpha blockers, because TNF alpha blockers are hugely expensive. They have huge side effects, and they should only be used in consultation with a rheumatologist. But steroids, many gynecologists would dare to use on their own. And
Yes.
the word of caution is that only use it not for unexplained, but where you see that there is a high natural killer cell count. If you want to use anything empiric, then my take on that is use probiotics. Use dydrogesterone, because these are safe empiric therapies that will do no harm. But steroid is not a safe empiric therapy, and you can have congenital malformations in the baby. So you need to take it with caution. And all these therapies that we talked about, like IVIG and steroids, we generally stop them when we see a good fetal heart and a good choledecidual reaction. We don't want to go beyond it. It is only during the implantation period, so which means from your luteal phase onwards till you see a fetal heart, which is like a 1 month period, I would say.
Yeah, I think Dr. Mala has put it very well. IVIG is also very expensive, so to try doing something with IVIG or with any TNF blocker, I think is not what the three of us want to give a message. I think it's very, very important that steroids also should be looked at with skepticism, because as Mala has very rightly said, congenital malformations and impaired sugars and all, which is going to cause problems.
Yeah. Thank you. And there is one more, is do environmental factors. I think this has been emphasized quite clearly by Dr. Mala, that environmental factors does have impact on the incidence of RPL. And they had asked this question, and about the immunotherapy in the treatment of RPL. So what immunotherapy is available, and how do you select the patients for this immunotherapy?
Amit, you take that.
Okay. See, as Dr. Mala very well said, that if you want to give immunotherapy, I think we could start with dydrogesterone, which is an immunomodulator. We know it will help us. But the other immunotherapies are basically done in centers of research. I don't think we should be advocating to them to everybody, be it IVIG, be it intralipids, because we have seen complications for patients. I think the side effects and the risk are much higher than the benefits. Paternal cell lymphocytes is another thing which crops up often. It comes as a seasonal favorite, but again, no meta-analysis or Cochrane data has actually shown it to be really very beneficial. So I would restrict myself by doing by putting them on dydrogesterone, and as Dr. Manju Puri and Mala has said, low dose aspirin, and now maybe 150 milligram instead of 75 milligram, and to add low molecular weight heparin would be a very, very standard treatment that we could offer these prothrombotic patients.
Yeah. Thank you.
So Mala, would you like to, Dr. Manju, would you like to add anything?
Yeah, no, I definitely agree with it, that dydrogesterone is the tool, I'm saying the drug which should be used liberally, I think. That's what is my personal feeling as well. And all the other therapies should be left in research setting. And so I'm very, very clear about it, that no one should venture upon these kind of therapies without a research setting. Yeah, that should be very clear.
Yeah. So there is another. I want to share one thing about the food.
Food, yeah.
Many years back, my teacher, 40 years back, they had one patient with recurrent abortion. I think 7 or 8 abortions were there. So patient again became pregnant and came to her. She told her to go back because she is not able to treat her. Then after 5 months, she came with full term. So she was very much surprised that how you read the pregnancy. She told that somebody, some white gave her some medicine. And she asked that Vaid and got the information about that vegetable medicine that contains Vaudin, Gokru, and Galo in 100 grams and Amla 200 grams. And that mixture given daily 15 grams, half in the morning and half 7.5 gram in the morning and 7.5 gram in the evening. And that works like that. And then she started studying in various patients. And she also read a paper in Foxy. We are also doing for last many years this therapy along with our all allopathic medicine like heparin and aspirin for alloimmune causes or APLA, and it will give you a very good result. Even in IVF patient now, I am all give to this therapy because there is nothing wrong. It is only a diet. It is slightly difficult in a taste to take for a patient. It's little difficult, but otherwise it works very well and definitely reduce the abortion. I have many patients where I have given only aspirin and heparin, low molecule heparin, and there is a no result. But when I add this, along with that, immediately patient reach the full term in 4 or 5 patients. So we routinely use it at many centers in Ahmedabad.
You're giving mainly vitamin C, anti-inflammatory agents.
Yeah, that might be right. Yeah.
All anti-inflammatory agents. And now
it may have some immunological role also. Because Vaudin and Gokru and Galo, this is a Rasayar Churna which is available in Ayurveda. The formula is more or similar to that.
I think let's give a clear message that this should be all supplementary.
Yeah, it is a supplement. It is a food, not the treatment. Yeah, you can supplement. Yeah, definitely.
I also said foods which are protein, high protein, which can sometimes give antigenic reaction.
Yeah, no, this is only a vegetable. It is all vegetable product.
Yes.
Yes, thank you very much. And there is one question from Dr. Sunita. She is telling that she's asking about the level of TSH to be maintained in the pre-conceptional period in a woman of recurrent pregnancy loss and hypothyroidism.
Okay, the ideal value would be between 2 to 4 for TSH. Now, some of these patients have subclinical hypothyroidism. So they could have a TSH which is on the higher side of normal. And I think this TSH should be corrected. When you supplement them with thyroxine, I think it is very important to add calcium because that is something which is important. And I think although the lab say from 0.6 to 6 is normal for a patient who is wanting to go for pregnancy, 2 to 4, because we also know that the largest cause of cretinism in children is hypothyroidism. So it's very important to maintain it between 2 to 4.
Yeah.
Some people say less than 2.5.
So, yes, cut off.
So it should be on the lower side of normal, not the higher side.
Yes.
Dr. Atish, he wants to know about what are the anti-cardiolipin antibody or lupus anticoagulant test. Are they essential criteria or for the initiation of therapy, or thromboprophylaxis can be started without laboratory diagnosis, only on clinical diagnosis?
Thank you.
I think I made it clear in the talk also that it is to be treating a patient, you should actually fulfill the criteria of antiphospholipid syndrome, which would mean 1 clinical criteria and 1 lab criteria. So it could be either lupus anticoagulant, it could be either beta-2 glycoprotein, antibodies against that. It could be, antiphospholipid antibodies positive. It could be any, but there has to be a combination of the two for you to be actually labeling it as a case of antiphospholipid syndrome. And in case you are doing it otherwise, you strongly feel, say, there is a patient who's had a, cardiac activity there and then disappears after 10 weeks, and you strongly feel it is that, then you need to talk to the patient and tell her that it is empirical.
Okay.
But in case there is a problem, then it would be a problem for the doctor, treating doctor as well.
One thing I want to ask you, Dr. Manju, is that we often say repeat the test.
Repeat the test. Yeah. I also wanted to ask this because many times we don't repeat the test after 12 weeks.
Recurrent miscarriages and other things having been ruled out, if you get an autoimmune test, would you actually wait for 12 weeks or you would start the treatment? Frankly, I would start the treatment. I don't want
Dr. Pataki, this is what happens. You are actually looking forward for anything coming positive. The moment it comes positive, you have a ground to actually start treating the patient. Yeah. So what I personally feel is that, we are not, the testing is also not standardized across all labs. Yes. That's one thing. And, in our own study, in 50 cases, we had so many positive because it was being done in a particular lab. But then it all depends. And then we are also not sure about the baseline levels in our population. So these are two factors.
I wanted you to highlight that APTT is more prevalently positive in India. And I also wanted you to point out if APTT is short, what does that mean? We're looking for a prolonged APTT, but in some patients, it's consistently shorter than normal or the control. So that also means a procoagulant state, and I wanted to highlight this to the audience. For the low resource patient, if you have to do only one test before you want to decide heparin and aspirin therapy, let it be APTT. But please don't do it without doing the test, because many studies confirm that unexplained miscarriages are not benefited by heparin and aspirin, and you would be wasting a lot of the patient's money as well as daily injections by giving her heparin. So I just saw this question in the chat box which said that I had a patient who had 2 miscarriages at 6 to 8 weeks, and I gave her heparin and aspirin and it didn't work. So if she's unexplained, first is to confirm the workup. Have you done ultrasound, 3D ultrasound? Have you looked at all other factors that we talked about? And if it is totally unexplained, don't give them heparin, aspirin. It doesn't work. Give them vitamin D, give them probiotics, give them dydrogesterone and tender loving care. And that will take the pregnancy through. And, as you said, diet modification, Dr. Tushar is very passionate about it. So
we have tried it.
I think you have to give the patient something to do. If you say, I don't give you anything, that actually lowers down her confidence of carrying the pregnancy. So whether
I put it very, very well by saying tender loving care. I think that is something which is so important, that they have one point of contact. They meet the same doctor. You spend some time talking to them. Maybe you do frequent sonographies for them to get that little bit of reassurance that everything is fine. And I think some of these unexplained patients are pulled through in such cases.
So I do a scan to listen to the fetal heart every single visit she comes, because there's no other way for me to tell her that your baby is normal. And the minute she listens to the fetal heart, she goes home so positive. Okay, come back next week and we'll listen to the fetal heart. You don't have to do a biometry. All she wants to know is the baby's heartbeat there? Is it alive? And this is a paper now in the BJOG on reassurance scans in RPL. And it said those women that had reassurance scans had a better outcome because they were de-stressed.
Absolutely. So this has been already explained. What is a dose of ecosporin to be started in a woman with RPL and history of preeclampsia as well? So
there's a controversy here, Maju. Can you help us clarify this? Dr. Kipros mentions in some lectures that PET prophylaxis dose of aspirin is 325 milligrams. And I'm not sure myself what is the right thing to do. So I wanted to ask you.
I think, Bala, across all guidelines, it is 150 now.
150.
That's what is the accepted dose across all guidelines. So we need some more literature to come before we actually switch over to 325.
Okay.
But there is a history of preeclampsia also. No? So 150, I think, with RPL additional I think 150 is the standard dose we usually give. Of course, we need more literature on that. And 325, as Dr. Mala is telling, I have to search the literature for that.
Yeah, there's one paper by the UK group on 325, and they started at 16 weeks. I mean, when we are talking about RPL, it's only 150, not more. But when you come to PIH prevention or PET prevention, then there is this controversy that at 16 to 20 weeks, should you step up the aspirin or no?
What about the progesterone, Dr. Varsha Jambgi? She wants to know about the dose of micronized progesterone for recurrent pregnancy loss. Usually, we don't prefer micronized progesterone. I do prefer the hydrogesterone. So, what is your opinion about this micronized progesterone?
I am all for dydrogesterone. So, would prescribe that as a choice.
I also
10 milligram. I agree. It's dydrogesterone that we would prefer to give.
10 milligram twice a day. That's what I would prescribe.
And how long you will give? Continue to give.
I give it till the NT scan, which is 11 to 12 weeks.
Yeah, same. Till 12 weeks is what I give.
Not beyond that. Yeah, that's what.
Then you substitute to micronized progesterone?
No, you just stop it.
Prevention. So this is the question always asked in RPL.
Yes. That's why I asked it.
Prevention. But that will only be when indicated. All RPL patients don't need preterm prevention. So if she's had a previous preterm labor, only that subset you're talking about switching to micronized progesterone vaginally or intramuscular progesterone. And that should be when you see a shortened cervix. I don't think...
And just I want to ask whether we should test the partner. You were talking about the DNA fragmentation and other things. So every patient of RPL, we always focus on the female partner. So we should and we must test the other partner also, male partner.
I always do a semen analysis and culture.
Yeah.
So that gives us a little bit of insight. If there are too many abnormal forms, then he's a candidate for antioxidant therapy. And you do not want to invest on sperm DNA fragmentation, but a simple semen analysis you can do. And many of them show us some kind of growth in the semen. Now, per se, the semen growth is not important, but what happens is there is subclinical endometritis with this semen growth. So the sperms are moving into the uterus. There's some bacteria colonizing the endometrium. They're altering the TH1, TH2 ratio. So that is why, for me, that semen culture is important. And then treating any male accessory gland infection like seminal vesiculitis will improve the outcome. But certainly counsel the male. I think we let the male loose. He can smoke, drink, and have his non-veg. And while the woman goes through all kind of rigorous diet, he also has to...
Yeah, smokers, diabetics, and even increased paternal age is something that we should keep in mind. If the husband is old, particularly over 50, I think we should keep sperm DNA fragmentation.
Yes.
I would like to make a point, Dr. Vidya. All the patients who have hyperhomocystinemia, it's important that we do a vitamin B12 testing because our patients are really, really deficient in that. At the same time, I would also like to emphasize that we give too much folic acid, especially to recurrent aborters.
And I also read about the folic acid supplementation to the male partner as well, because I had a talk on this hyperhomocystinemia, so I was just reading through. So there are sperm abnormalities in the male partner also with the folic acid deficiency, and we never supplement the folic acid to the male partner.
So
that's
I'm talking it a different way, that too much of folic acid supplementation can also be harmful.
Yes. Okay.
Vitamin B12 deficiency. So that's very, very important.
That also.
Folic acid supplementation is 400 microgram. And we give 50 grams.
Five. We give
5 times what is actually required.
Yes.
So,
I agree.
UK get shocked when we say we give 5 milligram. They say 5 milligram. 5 milligram. But tablets available.
But Manju, their diet is fortified with folic acid. Their wheat is fortified.
Wheat is fortified. Yes, yes.
I
Yes.
totally agree with Dr. Manju that we are neglecting vitamin B12, and now as I do a vitamin D and B12 level, because especially the vegetarians, because the vegetarians are all deficient in B12. Jain community, the vegetarian community should all have B12 supplementation. And I'm a vegetarian and I take a B12 every day because my B12 levels were so low. And if they're diabetic in the family, because the minute you take metformin, the B12 goes down to your bone.
Yes, yes.
What about the genital tuberculosis? Many times it is associated with recurrent abortion, and we do not know even because many times we are not doing think of that, or we may not taste for that. Dr. Patki, you have work over that.
No, I don't genital tuberculosis. Genital tuberculosis, but I do test my patients for genital tuberculosis with RT-PCR testing that we do on endometrium. I would also maybe do a hysteroscopy on these patients. One is to rule out any uterine anomalies, and second is to take these biopsies. Now, in our country, we do find a large amount of genital COX, and this is not now anymore restricted to the low strata. We have seen patients with all socioeconomic classes having this, and they need not have any pulmonary tuberculosis. So doing an X-ray chest may not really help you. Depending on which test you do, but then when you start treatment, I think it is very important that you do a multi-drug full treatment, and instead of giving empirical 1 month, 3 month, 1 drug, 2 drugs, that is actually causing more harm to the patient than any good. So I think if we diagnose somebody, I think it is very important to complete the full course of treatment, emphasize that to the patient. Generally, the patient is on a 4-drug regime for 2 months, and then we shift them onto 2 drug. I've seen some, I advise them for the first 2 months contraceptives so that they do not conceive, and then I tell them that they could possibly conceive, and I've seen a large number of patients spontaneously conceiving and carrying the pregnancy forward.
I wanted to ask you, do you switch to the gene expert test or you continue the RT-PCR?
No, we have moved to the gene expert test. We have moved to the gene.
Yes, yes. There is one more interesting question. How to suspect a genetic etiology based only on history? Can we suspect a genetic etiology?
Suspecting history is early miscarriages or blighted ovum. So if the fetal pole doesn't develop a heartbeat, or there is an empty gestational sac, there is more chances of it being genetic. But unless you test it, or the other thing you can look at is a family history of miscarriages. So if the mother says that my sister also had 2-3 miscarriages, and I am also having 2-3 miscarriages, you're alerted to the fact that it could be a translocation that we should be looking for. Or of course, it could also be a thrombophilia. I mean, it's not always genetic.
I think in our student days, we were taught of syphilis, which gives you increasing gestational age. I think the autoimmune gives you decreasing gestational age, and the genetic is one, as Mala said, very, very early pregnancies. They always come with an empty sac or a missed abortion in the first scan itself. So this is the way on history you can differentiate, but I think we need to supplement our history with a good test to confirm.
Yeah. You told about the testing of the products of conception, and which is a test for the couple testing. Which test you prefer and in which patient? And many times paternal karyotyping is normal, and sometimes we see the products of conception, they are having some abnormal karyotyping.
Yeah, that is the common scenario. So that means this abnormality just developed in the fetus, and the husband and wife have a normal karyotype.
Yes.
Patients actually do very well in their next pregnancy.
Yeah, that counseling we should do. So genetic, every time we don't have this genetic counselor. So we are the part of that genetic counseling. All the general obstetricians and gynecologists. And the take home message, I feel that we should not give a blanket therapy. The people are tend to give after 2 abortion, they start straight away with the aspirin and they start away with the low molecular weight heparin. One should not do that. That's what I feel. So I want one take home message from each of the panelists or each one of the speakers from their talk or message to treat this recurrent pregnancy loss. And then I want a comment on of my chairperson, and then I think we can end this. Yeah.
So my take home message would be that RPL is multifactorial. So there is nothing that will work for all patients. If she has a septum and you keep giving her heparin, you're going to have another abortion. So unless you diagnose what is the reason for RPL, don't start any empirical therapy.
Yes.
Yeah, I agree with what Mala has said. Is multifactorial, and important is that sometimes a patient may have 2 different causes. So you must do those basic 5 tests that we need to do as far as autoimmune, genetic, infections, hormonal, endocrine. These are basic tests that we have to conduct in each and every patient, because quite often you may miss out something. And as I said, no empirical treatment, but tender loving care, I think, is very, very important in those 50% where we cannot really find any cause for the miscarriages.
I absolutely agree with the both Mala and Amit. Basically, I think patients with recurrent pregnancy loss, they really need lot of reassurance. Like a race, you don't leave them alone. You carry them with their pregnancy to the end. And I think that is what would happen. And a thorough investigations would help you, and correction of all the small things. Say if it is lifestyle modification, that will also contribute. So reduction of weight, stoppage of smoking. So it is not only the drugs which you are giving, but I think it is the overall attitude of the couple and your own attitude, and stressing them and try to take the pregnancies forward. I think that is what is my message.
Yes. Sir, our chairperson.
Yeah. All 3 speakers are excellent in their field, and they have enlightened us in the field of RPL very excellently. And I think all the people will take home message very clearly that proper investigation should be done and try to find out the proper reason and then treat accordingly. That is the today's very clear message to everybody. Empirical treatment may produce some harm and you will be lost sometimes in the multi-etiological problem of RPL.
Okay. Thank you very much. And it was a really excellent webinar. Every time we indulge in our recurrent pregnancy loss, I always remember Dr. Mala, and I always fond of reading her books. And also the contributions from Dr. Amit and Dr. Manjupuri were excellent. And she only suggested to take these 2 speakers. It was really excellent suggestion, Dr. Mala. I really appreciate. Thank you very much. Thank you, Dr. Amit and Dr. Manjupuri. And maybe in future webinars also, I'll involve in a different way. Thank you very much. And this was an excellent webinar, one of my Food and Drug Committee webinars. And everything was discussed, like food means probiotics, drugs, everything was discussed. Thank you very much. I think almost every point is covered, and take home messages were very clear. What happens in the panel discussion is some cases are discussed and some things are not touched, and they have some unanswered questions. So thank you very much again. I just end, when the world says give up, the hope whispers, try it one more time. So that is what we always say about the recurrent pregnancy loss, and somewhere it clicks. Thank you very much. Thank you very much for the nice evening and the academic days.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.